Good afternoon or good evening, wherever you are. Good morning, maybe. This is Dr. George Duello in St. Louis, Missouri, in the United States, doing a presentation on the treatment of the prevention of total edentulism, the all-in-4 technique of the mandible. Dr. Maurice Salama asked me to come back on Dental XP to support previous programs on Dental XP that I've done on the all-in-4 technique, and Dr. Palomalo was on recently on Dental XP as well. So today we're going to be a little more clinically oriented in our presentation. I'd like to discuss some educational objectives that we're going to have for our program today. First, we're going to demonstrate the all-in-4 protocol as an immediate load protocol to prevent total edentulism. Secondly, we're going to discuss some specific techniques that are involved as well as laboratory recommendations for the all-in-4 procedure. And third, we're going to review maintenance and long-term care issues associated with the all-in-4 patient. So let's just kind of start with a little bit of an introduction and review. This has been covered in other Dental XP programs on all-in-4, but I want to re-emphasize these points. There are long-term published data on the all-in-4 procedure, specifically 10 years in the mandible and 5 years in the maxilla. All of these studies have pretty much showed very high clinical success rates for the all-in-4 procedure in both the maxilla and the mandible. We know that the marginal bone responds well for the axial and the tilted implant. The soft tissue around all-in-4 implants, whether they're axial or tilted, again appears to be very stable, and there has been several evidence-based articles, one of which I was the primary author, to review throughout the world all the clinical studies that were done on all-in-4 and the success worldwide of the all-in-4 procedure. So we know that the dental literature will support all-in-4 as a treatment modality for the patient. I think this explosive diagram is very good for getting a basic understanding of the all-in-4 mechanics. First, we have 4 implants placed, usually in the mandible, 2 axial implants in the anterior mandible, and then 2 tilted implants in the distal aspect somewhere near the mental foramen exiting the mandible. Those implants in this particular explosive diagram are external hex implants, which is my particular favorite to use with this particular procedure. On top of the axially placed implants in the anterior region, we usually put a 2 millimeter or 17-degree angled abutment to realign the prosthetic platform. The posterior implants are usually restored with a 17 or 30-degree angled multi-unit abutment. All of those abutments are held in place by retentive screws, and then the definitive prosthesis, which is usually made of acrylic and acrylic denture teeth, is retained by 4 prosthetic screws that hopefully come out in the lingual aspect of the fixed screw-retained prosthesis. So this is our ultimate goal for the all-in-4 procedure, is to have a fixed dental prosthesis. So today we're going to focus on a case presentation, actually showing some of the techniques involved in doing the all-in-4 procedure. So where do we start with the patient? Well, usually we're going to start with an exam, photographs. In this case, the photographs, this is a patient in her mid-60s who has had a previous prosthetic procedure involving dental implants and a conventional prosthetic procedure in the mandible not involving dental implants. Her chief complaint at this time is she is uncomfortable with the maxillary implant reconstruction and overdenture, and she knows that she's got some problems with her lower teeth and she wants to basically look better. So these pictures show her in smile and in repose. We see a close-up of the immediate oral cavity and lip posture in repose and smile. You can see that there is a minimum tooth display. There's some lower anterior display, which we know is usually going to be seen more in older adults. We can see some changes in the incisal edges. When we look at her intraorally, working from the outside in, you can see that she's wearing a maxillary denture of some type. There's been some wear of the incisal edges. She has a bilateral distal extension partial in the lower anteriors with 5 remaining lower anterior teeth. So what we discover is, as looking at these things, that she has some wear patterns. She might have some evidence here of some combination syndrome with over-eruption of the anterior teeth and a depressed posterior occlusion and a step in her occlusion. But you can see the wear pattern on the teeth. And this is where we start to really see what's going on underneath the prosthetics. In the maxillary arch, she had had 4 original implants placed, all with independent ball overdentures. She has lost one of the implants some time ago and just recently lost one of the implants, so she now only has 2 ball overdentures in the maxilla, and she just does not have good stability with these appliances. The mandible, you can again see that there are 5 remaining natural teeth. There is some slight over-eruption and irregular incisal plane with a slight step in the posterior. When you look at the occlusal views, again, you can see the partial in place and out of place. And again, in the maxillary arch, she has a relatively wide arch. She has a lot of alveolar bone width, but she doesn't have stability to her satisfaction with this ball overdenture. The denture that she's wearing, conventional construction ball overdenture, I would say that she somewhat has a oval shape to her occlusal pattern, and again, fairly decent vestibule. When the denture is out, she exhibits some of the signs of lip wrinkling, which she doesn't like. Also, there's been a downturn of the lip at the angle of the mouth here, and I think that's classically associated many times with a loss of vertical dimension. So we also look at a reconstructed panorex from a cone beam CT showing the remaining 5 mandibular teeth, the supereruption of the lower anterior segment, and again leading to the combination syndrome, and the 2 maxillary implants that are approximately in the first bicuspid region. Her sinus on the right side does exhibit some sinus pathology. So in the Bedrosian classification, I would say she has zone 1 bone, some zone 2 bone, and minimal zone 3 bone, with probably an SA 2-3 sinus in the posterior region. So a summary of the pretreatment records that are taken for an all-in-4 patient. Traditionally, we take photographs, cone beam CT, mounted models usually are taken with the teeth in place and with the teeth out in this case, and shade and mold guides are taken, as well as dental and periodontal records. The therapeutic concerns I have for this patient, we're kind of following the COIS outline, where we have periodontal considerations, some chronic early periodontitis, peri-implantitis with both of the remaining implants, and that's what she lost the other 2 implants from. She has no active decay at this time, so biomechanically she's stable. Function, I do believe we have combination syndrome and an unstable maxillary overdenture, and dental facially a worn denture and some loss of vertical dimension. Her risk assessment for perio is probably high for the remaining 5 teeth, biomechanically low for additional caries. Function, in this case, moderate to high risk assessment, and dental facially high because she's got some needs and expectations of what she wants to look like. The chief disabilities that I see right now is that she has got dislodging of the mandibular partials. She's not comfortable with it. She's had sore spots. And in the maxillary overdenture, she doesn't have stability with the prosthesis in function and speaking. And because of those things, again, that leads to poor speaking, denture sores, discomfort. We know that removable appliances in the mandible, especially in the posterior, may lead to additional resorption in the saddle regions. The fact that she has a couple implants in the maxilla still, even though they have peri-implantitis, at least is stabilizing some of the bone in that region. She does have potential pain associated with nerve impingement if she has the lower teeth tear, and of course the social and psychological aspects and conflicts that are associated with total edentulism. This patient has recently remarried, and she expressed to me her concern about, her social activities with her new husband and being able to travel and look good. At this time, I see the benefits of treating her with dental implants, or specifically the all-in-4 procedure, as we can achieve some bone and facial stabilization, improve function. She doesn't have to have denture sores or nerve impingements if we have a fixed appliance, improve speaking, and overall I think we can achieve some better dental aesthetics with her at this time. So where do we start with this patient once we've obtained the basic clinical records? Well, the first place we're going to start is, in my opinion, formulating a digital roadmap for the patient. So we take her cone beam CT, we put it into some software. This happens to be Noble Clinician, and we're going to evaluate what we have and where we can possibly place implants. So what you see here is we've gone in and we've identified both right and left mandibular canals. We've evaluated how much bone she has. We've also placed a Frankfurt type occlusal plane where we know we're probably going to have to do some form of alveolar reduction in order to obtain adequate clinical height for the subsequent prosthetics. In my previous dental XPs, I've talked to you about a minimum of 15 millimeters being necessity for the laboratory technician to design a bar and wrap adequate materials on that bar. In this case, you can see that if we are to do an alveoloplasty, we'll be somewhere past the apices of the teeth. That will create 19 millimeters of space with some additional leveling of the alveolus posteriorly. We should have more than adequate room for the subsequent prosthesis. The other advantage of doing this is we also know in this case we're going to put in 18 millimeter implants, so I think the likelihood of being able to achieve primary stability is going to be very, very good in this particular case. So this is our digital roadmap. We can order inventory things for her surgical procedure based on this, and I will have a laptop in the operatory with a large computer screen attached to it, so a surgical assistant can actually show me these images as we're going through the surgical exercise. Pre-surgically, we have to get some things ready. The first thing with our cast, we have to alter the cast, make some immediate dentures from whatever appropriate tooth molds and shade selections. Noble Clinician has already been done, as I just stated, for the alveoloplasty. We're going to make the maxillary and mandibular complete dentures in this case. We're going to make clear duplicates of the surgical immediate dentures, and I'll show you how that's critical and why that's so important in all of these cases. We're going to order and have available in inventory everything we need to do the surgery and the prosthetics. And lastly, we're going to do a pre-surgical conference, and we're going to do our informed consents before we have our surgical procedure. So finally, the day of surgery comes. We're going to do extractions, alveoloplasty, implant placement, and hopefully a conversion. And in this case, you can see we have carefully removed the 5 remaining teeth, done a full thickness flap from approximately second bicuspid to second bicuspid to locate and identify the alveolar anatomy, the mandibular canals, and foramen. Once we've done that, we're going to do our surgical alveoloplasty, reducing from the incisal edge to past the apices of the teeth, gaining about 19 millimeters of space. And you can see in most of these cases that there's pretty good homeostasis. There's not a lot of bleeding. Patients are pretty comfortable. These procedures can be done with a local anesthetic, PO medications, IV medication, and general anesthetic if you choose. So in this particular case, we're doing this surgery with local and PO Valium, which is common in our practice. Once we have the alveoloplasty done, we're going to start with our initial pilot osteotomies. In this case, we're using the malleable guide that I've discussed in previous Dental XP webinars. So we go ahead and place our malleable guide, place our 2 anterior axial implants first, and then go ahead and tilt and place our posterior osteotomies in conjunction with the ideal all-in-4 pattern. Once we do that, we take out the malleable guide, then we put in the clear duplicate denture to see how the long axis of the pilot holes corresponds with the teeth and the teeth setup. And in this case, it looks really good. We're very happy with what we see. So now we're going to go ahead and proceed with our implant placement. In most cases, again, as we drilled our pilot holes in the anterior segment, we're going to go ahead and put our 2 anterior axial implants in place, which are going to be 4 millimeter by 18 millimeter implants. I happen to like an external hexed implant for this particular surgical procedure due to the flexibility with the multi-unit abutments. So the 2 axial implants are placed, then the 2 posterior tilted implants are placed while identifying the mandibular canal and foramen. And in the slide on the lower right, you see all 4 implants in place, and all 4 implants achieve minimal stability with the torque evaluation of 45 Newton centimeters. So at this point, I'm very confident that we can go ahead and do the conversion, which in this case will be a direct conversion inside the oral cavity. So how do we do the direct conversion of the prosthesis? Again, using our explosive drawing, we're going to use multi-unit abutments to redirect the prosthetic platform for the ideal configuration for the final prosthesis. In the anterior, we're going to use, again, 0 degree or 17 degree multi-unit abutments, and in the posterior, we're going to use 17 and 30 degree angled abutments. The small prosthetic screws are different depending on what multi-unit abutment. For the angled abutments, you're only going to torque to 15 Newton centimeters, the small retentive screw for the multi-unit abutment, and for the larger straight, you can torque those to 35 Newton centimeters. So again, there's a different torque value applied to the prosthetic screw depending on whether it's an axial or straight implant. In this case, we've gone ahead and placed 2 2-millimeter straight multi-unit abutments on the anterior implants, and then in the center slide you see me using the duplicate denture again to configure the location of the multi-unit abutments in the posterior region, which are going in this case to be 30 degree angled abutments that are going to have a torque on the screw of 15 Newton centimeter. And again, you can see that the flexibility of the repositioning of the multi-unit abutment allows me to place it within excellent location for the final prosthesis and laboratory fabrication. So once the multi-unit abutments are in place, then we go ahead and put white protection caps on top of the multi-unit abutments and suture the patient for the closure of the mucoperiosteal flap that was performed for the alveoloplasty and implant placement. At that time, the assistant will load the mandibular immediate denture with Blue Mousse, and we will index intraorally the location of the implants, not the implants, but actually the multi-unit abutments. So you're seeing on the lower right side the indexing for the next procedure. So once that has been indexed, we go back to the laboratory and trough out either a trough or individual holes where we're going to now pick up or attach intraorally the multi-unit temporary copings to the denture prosthesis. And in order to do this, you can do it different ways, but in this particular case, we're going to pick up the 2 anterior implants first and then pick up the 2 posterior implants second. So we go ahead and isolate the intaglio surface of the tissue with rubber dam, and then we're going to use a fast set acrylic that's placed into injection syringe, monoject syringe, and we inject into the denture to allow the material to set and attach the denture to the anterior axial implants. So after all 4 implants have been indexed, we then remove it from the mouth, go to the laboratory where approximately half an hour to 45 minutes procedure is done to shape and polish the conversion denture, remove any distal extension cantilevers, and in the lower left, that's what you see. You see where we have removed the distal cantilevers, and now we've placed implant analogs on top of the multi-unit temporary sleeves, and we're going to index that into snapstone and then take a silicone impression. The purpose of this is to give us a model if we need to do any repairs during the 3-month period that the patient would be in the prosthesis, and also gives us a model where we can possibly fabricate indirectly a intraoral verification jig for the next step of the treatment. So in this particular case, what you're seeing here is the final conversion denture that was done from in the mouth with the patient. Usually the appliance has 10 teeth. This has an excellent AP spread, and is polished and ready to go back into the patient's mouth. So we go ahead and we put it back in the patient's mouth, screw it to place, check the vertical dimension of occlusion that was either prior to the surgical procedure or what is planned to change the vertical dimension to. And in this case, we have a very stable vertical dimension of occlusion, and we have a very stable prosthesis for the patient to wear in the mandible. This patient also received in the maxilla an all-in-4 procedure, but for the purposes of this particular dental webinar on Dental XP, we're only highlighting the lower at this time. So after 3 months of healing in a screw-retained fixed prosthesis, the patient now is ready for the first prosthetic appointment, which involves taking records, aesthetic evaluations, developing the intraoral verification jig, and the impressions. In this case, we're going to do a direct intraoral fabrication of the intraoral verification jig, and we're going to do that by placing open tray impression copings onto the multi-unit abutments after we've removed the conversion prosthesis. We then take dental floss and figure eight the impression copings with the dental floss, and then flow, in this case, GC pattern resin along the dental floss to make a rigid intraoral verification jig that will be captured with a stock tray that's been modified and opened for access to the screws of the open tray impression copings, and we're going to use a polyether impression to take our record. And again, what we're seeing here is 360-degree clearance with the open tray impression posts so that we can gain access to them after the polyether material has taken. And now we've loaded the tray with our polyether and placed it in the patient's mouth for a 3-minute set. Polyether has a particular characteristic called snap set, so it takes about 3 minutes for this material to set in the oral cavity. Once the material, the impression has been removed from the mouth, polyether requires a 30-minute setting period before it can actually be poured. So during that 30-minute setting period, we can go ahead and box the lower impression. We can take some form of a soft tissue gingival moulage and inject it around the neck of the implants. Go ahead and box the impression, and after 30 minutes, go ahead and pour the impression. It is critical to use a type 4 dental stone that is made for CAD work and has an extremely low expansion characteristics. In this case, it is 0.01. So the material is very, very low expansion, because what we're going to do in this case is use a CAD-CAM technology via CNC to mill a titanium bar. So precision in the master cast is critical for these procedures. And again, we're going ahead and completing the pour. We'll set that cast aside, let the cast set, and then once we remove the cast, we can trim it according to the guidelines that we previously established in the clear duplicate denture, and also see how our master cast looks relative to the prosthetics that are going to be developed next. So the other way that you can evaluate for a jig is to do an indirect method, and this is the indirect method. So what you would do in this particular case is you would have probably taken an impression with a closed tray impression technique, have a model poured up, and then on the closed tray you would place your impression analogs as opposed to doing it directly in the mouth. You would do the same thing. You would lute the impression copings together in a figure 8 configuration, and then take, in this case, GC pattern resin, lute all of the multi-unit abutments in place. Then take a very small sectioning disc and section in between each section the verification jig, and also number and label either 1 through 4 or A through D each individual impression post, so you know how to reorient that in the mouth. Then you would go back to the mouth with this impression indirect technique. You would lute together in the mouth with GC pattern where you had separated with the separating disc, and then go ahead and take your polyether impression. So whether you do it outside of the mouth or you do it directly in the mouth, I don't think it really matters. But what does matter is that you do use an intraoral verification jig and immediately handle your impression properly so that we have as accurate a cast as we possibly can. So once we have developed our master cast, we can go ahead and do wax rims, 2 setups, and final jaw relationships. In this particular Dental XP program, I'm going to show you a slight derivation over the traditional technique of developing the prosthetics. We actually had an extremely good conversion of the maxillary and mandibular denture. The patient was happy with the tooth position, phonetics, and aesthetics. So since the conversion denture is really already in place, we can use the previously used clear duplicate denture to cross mount and attach the impression to the master cast. So we don't have to, in this case, do a wax rim and those traditional things. So a Cois facial analyzer is used to position the maxillary cast, and the maxillary impression was actually taken not with a stock tray, not with a custom tray, but was actually taken with the previously fabricated clear duplicate denture. So once we have that established, we can go ahead and put the mandibular cast in place using, again, the previously formulated clear duplicate denture. So those actually were used in this case to put the cast together. You can see in the Boley gauge in the lower left that we have adequate occlusal space here to formulate our prosthesis. The laboratory technician will go ahead and fabricate base plates and do a denture setup based on the previous duplicate dentures that are used to mount the cast. So he goes ahead and does his setup. Then we can go back to the mouth and we can, again, look at the vertical, horizontal, facial, occlusal, and phonetic records of the patient. And the patient obviously likes these. They look good, as do the conversion dentures in her mouth. So the next appointment, we're going to go ahead and tell the technician to fabricate the CAD/CAM milled, CNC milled bar. This is an atypical bar design. It's not what we call a wraparound. We had this design for some additional mass to compensate for the patient's occlusion, and there is a cantilever that's limited only to 10 millimeters on the distal aspect of this frame. So the framework can be tried in by itself, or the framework can be tried in with the teeth, again, waxed over the framework for the maxillary and mandibular try-in appointment. And again, that's what we did. We went ahead and had the bar covered with the wax and teeth that had been previously accepted by the patient in the prior prosthetic appointment. And again, this is just kind of a confirmation that everything looks good and she's happy. We do a Sheffield test on the bar by screwing one screw in the right side, seeing if it lifts on the left side, and then reverse the process, one screw on the left side, see if it lifts from the right side. And again, with radiographs in that test, we know that this prosthesis is basically passively sitting in place. And we can now tell the laboratory technician to go ahead and finish the prosthesis and deliver us a final prosthesis for intraoral insertion. So we're going to show you some photos. The technician in this case did an excellent job. We have nice characterization. The patient has already accepted the value associated with these teeth. So we're very happy with what we see. This is a picture of the maxillary all-in-4 prosthesis that's going to go in the patient. We have tremendously good AP spread with this patient, almost back to the second by first molar region, which is typical for maxillary appliances. In the mandibular appliance, you can see the access holes are somewhere near the, again, second by first molar region. And again, excellent characteristics and aesthetics with the lower appliance. These are showing the occlusal surfaces and where the exit holes for the all-in-4 procedure on, in this case, to minimize the AP spread. One of the things I want to point out in this Dental XP program is that it's important to inspect the intaglio surface of the prosthesis and where the multi-unit attachments are to the denture. And in this case, you can see that the acrylic has been brought up to the rim of where the prosthesis would seat. And if this is the case, generally what you're going to find when you put the denture in place, the patient's going to complain. There's going to be some tissue impingement when you seat the denture. It's going to be uncomfortable because they haven't had any experience with that while they're in the conversion prosthesis. So one of the things that I recommend you do is put the a protection cap on the multi-unit abutment, as you see on the right side. And once you put the protection cap on, you want to clear 360 degrees any acrylic or biomaterial that might impinge upon or pinch the tissue when you seat these appliances, because we want this patient happy. We want them comfortable when this definitive prosthesis goes in. So by putting a protection cap on, you can't nick up the head and the prosthetic platform, so it seats back in the patient's mouth in a comfortable manner for long-term retention. So this is the final prosthesis for this patient. You can see that Carol's quite happy, I think, with it, in repose and with smile. I think she has a more youthful appearance. I think this has helped her by increasing the vertical dimension, reestablishing a new occlusal plane without the combination syndrome. So I think this is an excellent result. Up close, you can see how the lips look. I think she has very appropriate displays now of maxillary and mandibular anterior teeth. When the lips are retracted, you can see that there is an excellent fit of the prosthesis against the intaglio surface, and generally the parameters that we look for are established here and are excellent for this particular patient. On the occlusal aspects, we seal the holes, both mandibular and maxillary, with Teflon tape, and then either put some type of a light cure material over the access holes so we can gain access to them again when we go back in to remove it for hygiene. So again, placement looks great. We're very happy. This radiograph shows the maxillary and mandibular all-in-4 procedures. I think it's a little bit of an illusion in the mandibular that there isn't any tilting. As you saw in the surgical procedure, there's clearly tilting of the implants in the distal, and sometimes panoramics will do this. You can see that the frameworks all seat very well, and there is a minimum distal extension, usually 10 millimeters, on the maxillary and mandibular prosthesis. So I'm quite happy with that, and I think the patient is quite happy. This large view here shows how nicely she looks and how well she's doing with the prosthesis in place. So to compare, let's just kind of look at where she was. In the conversion prosthesis, they usually have 10 teeth. In the final prosthesis, they have 12 teeth. I don't see a necessity to cantilever to the second molar region, and I think this is well within the boundaries of a good AP spread. In the maxillary appliance, we have, again, a 10 millimeter cantilever. You can see that in the conversion prosthesis in the maxilla, we were actually able to keep a first molar, so there really wasn't a big change between the conversion prosthesis and the final prosthesis for this patient. How long did this take? We saw her initially in April of 2011 and then finished the procedure in June of 2012. So by no means is this a quick fix. I think a lot of people think the all-in-4 procedure is some kind of quick fix alternative for patients. And in fact, the thing that we want to do is we want to stabilize the patient. Many of these patients travel, they live in one city or another in the winter, they go to Florida or Arizona, so they travel, they can maintain their normal lifestyle. So the key, in my opinion, is getting them into the conversion and prosthesis. Then you can proceed at some type of schedule or pace based on the patient's lifestyle, their travel, their finances, but the bottom line is it took us, about 12 or 13 months to complete this patient's treatment from beginning to end. Again, showing the lip posture and tooth display from the pre-treatment to the post-treatment. I think there's been a good improvement. Showing the denture prosthetics, I think look much better. The gingival prosthetics look very good in this case, very natural, and she's happy with the tooth form. You can see that she had the previous combination syndrome. The maxillary overdenture has been eliminated, and now she has screw-retained prosthesis in the maxillary arch. The alveolar bone has been stabilized. because we know that implants maintain bone, and I doubt that this patient will have any loss of vertical dimension from a osseous standpoint. They could have loss of vertical dimension from a prosthetic standpoint, but not from the osseous standpoint. So again, this radiograph confirms that we have good AP spreads, good stabilization, long implants in both jaws. So in my opinion, what is important to discuss with this particular case is that the amount of time that this patient was actually edentulous was about 2 hours, which, if you think about it, my orthopedic colleagues are extremely jealous. If they have to remove a leg for whatever reason, an AK or BK amputation, they can't rehabilitate the patient immediately after that amputation. They have to do a stump revision. They have to let that heal. The patient has to go to physical therapy. Then prosthetic impressions are taken, a prosthesis is made. It's a long, drawn-out prosthesis. But in this case, it took basically 2 hours to convert her to a fixed prosthesis. So the amount of time this patient actually wore a removable prosthesis after surgery was 0. And because that was 0, she never had denture sores. The time from the initial diagnosis to treatment, I told you, was from April 2011 to June 2012. What I find as a result of doing the 4 above steps is that the patients have a high degree of satisfaction associated with the all-in-4 procedure. Now, the all-in-4 is one of the procedures that are available to treat patients with total edentulism. You might put 6 implants or 8 implants or use zygomatic implants or pterygoid implants. I don't care what implants you use. What I care is that you try to achieve as a goal some type of fixed temporary prosthesis. We know that that's not going to be possible in all cases because we don't achieve primary stability with the implants. But if our goal is to not let patients suffer, our hope is that we will be able to do immediate load as soon as possible and all the benefits associated with immediate loading. Maintenance. One of the most common questions I'm asked by dentists and or dental hygienists when I lecture on this particular topic is, how often do you remove this appliance? What do you do to clean it? Well, first of all, I can tell you that when you screw these appliances down, the retentive prosthetic screws have a proprietary coating on them that's called True Torque, and that proprietary coating is removed when they're torqued to place. So my recommendation first for the prosthetic screws is, if you are going to take the appliance off and you are going to put it back on, you should have new screws to retain the prosthesis. The other thing I recommend is that you remove it only when it's necessary on an individual case-by-case basis. Some of the patients who have these prostheses in our practice or other types of traditional fixed implant prosthesis have never had the prosthesis removed. Their hygiene is immaculate, the tissue looks great, the patient is not exhibiting any significant occlusal wear on the prosthesis. So why would you want to remove the prosthesis? As opposed to that, we have some patients who, in some form or manner, I don't know if they know how to get a toothbrush to their head, but they are not as adept or skilled with their oral hygiene, and those patients require that the prosthesis removed more frequently. Some patients it might be every 3 months, some patients every 6 months, some patients every year, some patients every 2 years. So when the appliance is removed, it's based on the individual needs and case assessment of the patient. And that is really one of the discriminating things. I hear many people talk about, well, I like removable implant prosthesis because the patient can clean better. In my opinion, I have seen that clinically been true and not true. I've seen patients with removable appliances with immaculate oral hygiene. I've seen patients with removable prosthesis that have horrific oral hygiene. I've seen patients with fixed implant prosthesis with excellent oral hygiene, and I've seen them with poor oral hygiene. So the hygiene of the patient, in my opinion, is not dependent on the prosthesis delivered, but the desires and skills and capabilities of the patient who has that prosthesis. So I, in our practice, try to do everything in my power to make the patient move towards a fixed appliance, because I believe it gives the patient a better quality of life, something that acts like teeth, chews like teeth, and is not removed at night and put in a glass. So for our patients, maintenance is not an issue. Sometimes we alternate or we do the maintenance depending on the referral or patient that's involved in the particular case. So let's summarize what we've talked about today. What we've talked about today is a procedure that leads to a screw-retained fixed prosthesis, the all-in-4 procedure. And in this case, it's not an explosive diagram. You see the prosthesis in place on 4 implants over multi-unit abutments. So the all-in-4 procedure allows us to have a fixed screw-retained prosthesis. In my opinion and observations, removable appliances can have a negative impact on the patient's life. Dentistry has many tools to eliminate or prevent removable appliances, whether they're on teeth or on dental implants. The all-in-4 procedure is just one of the tools that are available for avoiding total edentulism, and the quality of life for a patient can be significantly improved with a fixed prosthesis. And again, I think dentists intuitively know this when they see partials and or flippers or stay plates or temporary removable appliances, whatever you want to call them, and a patient goes to a traditional fixed prosthetics, 3-unit bridge, 4-unit bridge, or whatever. We know that patients are more satisfied with those appliances than they are with the removable type of appliances. So in summary, the educational objectives for this program today on Dental XP have been to demonstrate the all-in-4 protocol as an immediate load to prevent total edentulism, to discuss specific techniques and laboratory recommendations for the all-in-4 procedure, and review maintenance and long-term care issues for those patients with all-in-4 prosthesis. So at this time, I'd like to thank Dr. Salama for having me back on Dental XP. I'd like to thank the corporate sponsors for this program, Noble Biocare and Salvin Dental, for supporting me with prosthetic and surgical componentry that allows me to deliver this kind of care for our patients. So I hope this has been an addition to the previous Dental XPs done by myself and Paulo Malo, and focusing more on a specific case and specific techniques. So I look forward to you viewing this on Dental XP today, and I also look forward to your questions and comments and getting back to you to answer any specifics you might have regarding this procedure. So thank you, have a good day, and enjoy.